Good morning. My name is Tom Conchio. I'm a family health team pharmacist with the Thames Valley Family Health Team. This recording is a part 2 to heart health. I encourage all participants to take a look at the part 1, which happens to be our dietary through our registered dietitians within our organization. Lots of great information there, but we separated it just because there's lots of information out here. So welcome to part 2. So let's have a look to see what we're going to be talking about today. Today's session is going to be about a half hour or so, maybe 40 minutes, and we're going to be looking at a few different factors aside from dietary. First ones are going to be alcohol and smoking and its effects on cardiovascular disease or heart disease. We're going to also look at exercise and activity, and the bulk of the section is going to be looking at medications then as well. So let's take a look at alcohol and smoking. Obviously not a surprise that we're putting it here, but you'll see the new drinking guidelines for Canada. These were come out recently, and they are a bit surprising compared to our previous ones. I think an important note is that they are evidence-based as well. So 0 drinks per week, we know, does not infer any type of additional risk for cardiovascular disease. No surprise there. We do know that there can be some consequences, even if 1 to 2 standard drinks per week. And the consequences of that one, you'll see on the right-hand side, the risk of atrial fibrillation. This is an irregular heartbeat, increases with each drink, starting at 1, and then it increases to 2 to 3. And these are incidences of having that atrial fibrillation at the time of drinking. So that's important to keep in mind. If we're getting up to 3 to 6 standard drinks per week, or about 1 a day, you do actually increase the risk of developing certain types of cancer, specifically breast and colon, and among other types of cancer as well. Where we see the biggest effect on cardiovascular health is going to be when we're doing at least 1 drink per day on a weekly basis. Your risk of heart disease or a stroke increases at that rate, and each additional standard drink over the 7 or more radically increases the risk of alcohol-related consequences. Some of that cardiovascular, more so can be your risks of cancer again, and then other instances that may occur. So when we're talking standard drinks, it's important to understand that we're talking all types of alcohol. You'll see beer, and this is for 341 milliliters. So if you look at the picture of the beer cans, these are right halfway between the cans that we see sold on the market, the 330 mil and the 355. The 355 is pretty standard right now. So I think the 341 is just somewhere in the middle of those two. You're also the ready to drink or the pre-mixed cocktails will be about the same size can as well. Wine, we're looking at about a 5-ounce glass of wine. And spirits, the accepted equal amount is going to be about 1.5 shots or ounces of the spirits as well. Calorie wise, you're looking somewhere for a light beer, you're looking somewhere in the low 100 kilocalories per drink. And then it goes up to the high with, the spirits are slightly lower. And they'll be somewhere in the 80 or 90 calorie range. And I think the highest amount of calories is going to be found with the 500 milliliter the beer, and just regular beer, you're getting up to about 155 calories. So in case people are wondering about calories, our concern is really just going to be the alcohol itself. That's going to obviously contribute to some of the things that happen with the heart disease. So really the bulk of this section is really just to have you choose an amount that you want to drink, knowing that the 0 is really the only one where we know that there's no consequences. From a cardiovascular risk standpoint, we're trying to minimize less than 1 per day. So if that's going to be your goal, by all means, we invite you to kind of think about that and to set your goal and then to stick to it as well. We do list on the slide a few ways you can do it. You can drink more slowly from an alcohol standpoint. Drinking lots of water or non-alcoholic beverages in between is good, and also eating before and while you drink as well is going to actually decrease the amount that people drink overall. Smoking. No surprise that this is going to be one of the topics that we talk about. If you signed up for this session, you have been able to successfully go to our program section of the Thames Valley Family Health Team. And this is where you're going to also find information or a video or support to help you with quitting smoking as well. So you'll find that video there, and that video is really going to be a good introduction to individuals. If you are looking for additional support, this is the intake, or this is the way that we have people come into our additional support of seeing a provider, is we do ask that you do view that 33 or 35-minute video ahead of time. And it's called Butt Out. If you're looking for the name of the actual program itself, it's called Butt Out or Smoking Cessation. So again, it is going to be required for anybody who's wishing to speak to a provider or to access some of our free nicotine replacement products and other programs. So let's talk about movement and exercise. Obviously, not a surprise here when we're talking about heart health. So the sitting is the new smoking. And by sitting, we're talking about being inactive, usually in a sitting position. And we have some interesting data to support the fact that sitting for very long periods of time actually increases your risk of all-cause mortality. So we know that by sitting more than 7 hours per day, and this includes work, this includes some screen times, maybe in the evenings as well, it actually will have a dramatic effect on that all-cause mortality. So people are actually dying earlier if they spend a lot of time in that sitting position. So keep that in mind. So again, not being active is really a key risk factor for that heart disease. How we think this occurs actually is interesting. We think it actually, by sitting or being sedentary, it increases lipids or your cholesterol levels. And these cholesterol levels will actually increase the amount of visceral fat or fat around the organs. Once that visceral fat is in place, it causes inflammation of the actual arterial or vascular system. And this inflammation is part of the process that builds up those plaques on the arteries that we call coronary artery disease. So that's really kind of how it happens. People are a bit surprised to know that just sitting is a really significant factor. So we encourage people to get up, get moving. And interestingly, if you do spend long periods of time sitting, even if you do other activity at other times, you're still at risk. So that's really important to understand. So let's talk about how we can get moving. We actually have the 24-hour movement guidelines by the Government of Canada, and we talk about the 4 S's. You'll see them there as well. So we have the first one we want to talk about is really going to be sweating. It's going to be physical activity itself. We're recommending about 150 minutes of moderate to vigorous exercise. And what that means for most people is things like an actual brisk walk, can be anything that'll, raise that heart rate up as well. We're looking for bouts of about 10 minutes or more. It doesn't have to all be at once, but it does require about 10 minutes at a time at least. And we do recommend as well that individuals would then also have some resistance exercise. And we're going to help you with some of that stuff as well as we go along with these slides. The next one is going to be stepping. And again, if you're not into that sweating part, you're not able to do it for whatever reason, we do think that stepping is actually shown to have some benefit as well. The suggested amount is going to be about a goal of about 7,500 steps per day. Many individuals have those watches that they can actually program or will tell them how many steps they're doing. And again, we do know that breaking up long periods of walking, and maybe do them in chunks of 20 to 30 minutes is very effective. And even throughout the day itself, we know that people's walking during work, maybe taking the stairs instead of the elevator, really does help as well. If you're actually not able to do that 7,500 steps yet, then increase by maybe about 500 steps per day and do that every 3 to 4 weeks, and just to have that new goal. And again, small improvements will make a big difference, and eventually you'll be able to get up to those higher steps. If you can get to 10,000, that'd be great, but we're definitely recommending about 7,500 from a cardiovascular benefit. Sleep, no surprise here. People would love to get more sleep, but again, we're recommending about 7 to 9 hours of good quality sleep. And for many individuals, this is very difficult. If you're one of those individuals, again, I'm going to suggest one of our programs. It's called Dream On, and that's going to be our cognitive behavioral therapy for insomnia. So if you're having trouble sleeping, please look at that program. It's a great one. But again, the limiting the time that we're talking about, again, we include sitting there as well. And again, we already talked about the negative benefits or negative effects of sitting or being sedentary too long. So we want good sleep and we want to get up and get moving, not sitting for long periods of time. These are just some examples of some aerobic exercise: walking, swimming, cycling, jumping rope, even dancing. A lot of people don't think of dancing or gardening, but they can be as well. Anything that gets up that heart rate a little bit can be classified. So the question is, what do you want to do? And some of it will be seasonal as well. So maybe talk to your family and friends to think about options that may work for your schedule. We do include here as well just a small example of what an aerobic training program could look like for a beginner. So in that first week, maybe just every other day, they're doing a 10-minute walk at an easy pace. And this is an individual who doesn't do any activity. And as you can see, by the end of about a month and a half, they are getting out for at least 5 days of the week. They're starting up with about 10 minutes of an easy walk, and then they've been able to move up to about 25 to 30 minutes, maybe a slightly faster pace with another warm down as well, or a cool down, we call it. And again, this really is a realistic schedule for many people, and we just include that here just for your information. Resistance exercise, very important. This can be found on the Heart and Stroke Foundation, and if you've signed up for this program, you'll have access to some of the resources, and these pictures and examples are in the actual resource section for you. And again, some of them are going to be seated, some are going to be standing. And really, we're just trying to use muscles against a force. Sometimes it's gravity, sometimes it's the use of bands, sometimes very small weights. You don't need to have anything special at home. Even gravity works well. And we're really just trying to use muscles, and that's going to really help as well. And sometimes just using those muscles can get that heart rate up as well. But we're trying to keep them strong as well as the cardiovascular health as well. And some for the lower body as well. Again, you don't require any special equipment. Just make sure you have a sturdy chair, not on wheels, really works quite well, or a mat on the floor. Exercising 30 minutes every day, we know there's benefits. We know there's evidence to say that. It's just a matter of getting started, and just start where you are, not to worry. Just get out there and do it. Little all things begin come from small beginnings. The seed of every habit is a single tiny decision. Don't think too far ahead. Set a goal for today. Maybe that goal is to look into the type of cardiovascular exercise that you want to do. Maybe the goal for tomorrow is going to be maybe try something for about 5 or 10 minutes and then see how it goes. Just start at a really small step, but just try to increase with that if you can. All right. The bulk or the rest of our presentation is going to be looking at medications as they relate to heart disease. We're actually asked this question quite often: will my medication prevent a heart attack? And I think probably the best way to do that is really just look at the risk of developing an actual heart disease or a heart incident, and then we can look at maybe the benefit that medications may have from that. So let's have a look at that. When we start talking about estimating heart risk, there's a lot of different ways we can do that, but they are mainly based on the fact of some of the risk factors that individuals may have. So we talk about the non-modifiable risk factors being things like your age, male or female, maybe the ethnic background, and maybe some family history. You can't do anything about that, but we can control, and that's why we call them modifiable risk factors, the four big ones: blood pressure, cholesterol, sugar. It says diabetes, but really sugar is what we're looking for. And then also smoking. Those are the four modifiable risk factors for heart disease. Other factors do come into play from an overall risk standpoint. And we talked about physical activity, talked about alcohol, and obviously stress as well. You'll see in this picture that we can classify individuals in three categories: low, moderate, and high. automatically you may think you have some good factors in your favor. Unfortunately, we know that if you have had an event or a heart attack or a stroke or other cardiovascular event in the past, you're automatically at high risk of having a future one as well. We get that question right off, so we just wanted to make that clear to individuals. You're kind of wondering, how can we do this? Well, your doctor will use a number of screening tools or estimation tools, and the big one that many people hear about is Framingham. There's a lot of different ones out there. A really patient-friendly or individual-friendly one is going to be a website called myhealthcheck.com, and that'll give you a heart health indicator, which is really just kind of a heart age. So it's always a fun one to go. So go myhealthcheckup.com, and that usually is a good one for individuals to use. We're going to be looking at some examples using the CVD calculator, and we'll see that here. So let's have a look. When we talk about cholesterol medications, we're talking about a lot of different things here. So different classes, and you'll see some of these here on the screen. The statins, we're going to talk about a little bit more in detail, but this is really the class of drugs that cholesterol medications overall that people think about when they think about heart disease. You'll see a lot of different other kinds there as well. So let's talk about the statins. What does it mean when I say statins? These are going to be a cholesterol lowering family, and the big ones that people recognize are going to be things like Lipitor or Crestor, or you'll see the chemical names atorvastatin and rosuvastatin. Interestingly, these slow the cholesterol being made by your body. The body has a certain set point that it likes to be at, and this is where we'll see often a strong family history will often coincide with a strong family history of high cholesterol. Again, meaning that if you have a family history of people in your family having a lot of heart disease, part of that might be just because you have a high cholesterol level from a set point. So again, this class of drugs kind of helps decrease that risk down by decreasing the amount of cholesterol the body produces. The dosages can be on a low, moderate, or high intensity range. And how the statins really work is they work by decreasing the total amount of cholesterol, but they also, aside from their production of cholesterol or controlling that, they do also have other effects from again, decreasing inflammation of the vascular system. And we think that that's how these medications work well to prevent heart disease, or at least decrease the risk. And again, we're not just talking about cholesterol here. Statins may be prescribed for a number of different reasons. Part of it is going to be because maybe you have a family history of high cholesterol. We also know that maybe you have some plaque buildup, and what we know of well is this class of drugs will stabilize those plaques, so these plaques are less likely to clot, less likely to actually have a piece kind of come off and cause a heart attack or a stroke. So there's lots of different reasons why you may be on a medication from the cholesterol family, and just to discuss specifically what for you with your provider at your office. So when we talk about preventing heart disease, we talk about two types of situations. We talk about primary prevention, where an individual has never had a problem and then they have their first episode. We also will then talk about secondary prevention, is where an individual may have had one or more episodes in the past and we're just trying to prevent another one. So when I say primary prevention, that's preventing your first incident of cardiovascular disease. And then the secondary prevention is really just trying to block that next one from happening for you. So interesting. Let's talk about this reduced cardiovascular risk. So statins, or cholesterol medications, statins overall will reduce the relative risk by about 25 to 40%, and it will decrease absolute risk by about 10%. And what we mean by that is, it's probably easier to see in a picture. So let me explain that to you in a picture. So a quick stats lesson. Would you take a daily medicine that claims to reduce your risk of heart disease by 40%? In the same voice, what about a medicine that reduces your absolute risk from 2% to 1.2%? And how about a medicine that reduces your risk from 25% to 15%? Surprisingly, depending on how you actually manipulate the numbers, these all three of these examples are actually the same thing when we're talking relative risk versus absolute risk. So again, let's look at an example, really helpful way to do this. For our example, we're going to use Mr. Bean. So Mr. Bean's a 63-year-old male gentleman. He is not a smoker. He has no incidence of atrial fibrillation. He does happen to have diabetes, and he has high blood pressure that's being treated currently. He has not had a cardiovascular event. So for Mr. Bean, it's going to be a primary prevention. And those are his blood pressures and some of his cholesterol numbers for you to look at there. So if we look at Mr. Bean and we're going to try to calculate his primary prevention risk, or what's the risk of him having a cardiovascular event, we know that over the next 10 years, based on using one of the screening tools, 25 people like Mr. Bean will have a cardiovascular event in the next 10 years. That means 75 people in this out of 100 will not have an event. So you might be in the category where you're going to be in the orange bubbles, which are going to be, yes, I might have an event in 10 years, or you might be in the other one. So when we look at these numbers, what do they actually mean? Well, guess what? So from a relative standpoint, we know, I'm just going to go back up on screen. We know if it's 25 out of 100, that's then going to be the actual risk itself is about 25 people out of 100 or 25%. And that means 75% does not. But if we give you a statin, so let's say you take a statin. So look at those orange bubbles. Overall, if 100 people took a statin, we'd get an additional 10 people who would not have a cardiovascular event. So that's important to realize that 15, even if they took cholesterol medication, are still going to have an event in the next 10 years. So we can't get rid of the risk totally, and that's why we call it a relative or an absolute risk. So let's see what those numbers mean. Relative risk is the decreasing it by about 40%. We know that we're going to be doing 10 out of those 25 people who are going to have an event. So relative to the other ones, that's a 40% decrease. Absolute risk reduction was 10 less people out of 100. So the absolute number, I think, is a bit easier for most people to understand. It means that if I take medication, I have a pretty good chance of decreasing my likelihood of having an event. So just a bit tricky with the relative versus absolute. When we're looking at treatment with medications for cholesterol, we really want to decide, are we going to treat everybody or do we treat certain categories? As mentioned earlier, if you've had a cardiovascular event, you're no longer in a primary prevention, you're in a secondary prevention. And that's going to be that group on the right-hand side where the risk is greater than 20%. We definitely want to get a statin, or we know there's benefit to a statin, and your doctor's going to strongly recommend it for you. The risk for the 10 and 20% are low and moderate. And really that has to become a discussion about some of the other risk factors that you might have, and then whether whether the statin's going to have any benefit for you. Because once you're going to be starting on a statin, it's important to realize you may still have a cardiovascular event. Your risk is decreased, but that also means that you're going to be on these medications for the rest of your life. So those are important decisions for you and your doctor to make. What can happen with these medications? Obviously, these medications have some benefit, but all medications have the possibility of having risks. So we call those side effects. This does not necessarily mean you're allergic to them. It just means that you might have a side effect, and these are often temporary. So things like a little bit of a stomach upset or GI, you might get some headache. We also know that individuals' muscle aches can occur, and this is actually not a problem if it's just a small amount of muscle ache. If the muscle aches become very problematic, then that might be enough for you to say, you know what, I just don't like this. I'm not able to exercise. I'm very uncomfortable. And that may mean that you have to try a different one, for example. And we do know that it can have an effect on liver enzymes, so the doctor may do some blood tests. These are going to be the more common side effects. The less common side effects are going to be things like muscle or kidney damage, and this is going to be much more severe. And these are ones where we definitely need to stop the medications. Surprisingly, we do know that individuals who take cholesterol medications, for probably 1 out of 250 individuals on these medications, may develop diabetes. And people say, well, then why would I want to take that? Well, it's important to understand that you're also going to save probably 10 to 20 people from having a cardiovascular event. So there is going to be that relative risk of diabetes, but a much higher relative risk of having a cardiovascular event. So it may still be recommended or beneficial for you. Liver failure, 1 out of 200,000 individuals, very, very rare. And that's why the doctor wants to do some of those liver enzymes. So when it comes time for the blood test, do not miss it. Go do it. So let's talk about another class of medications we use for cardiovascular disease. This is going to be the blood pressure medications. These can run into a few different classes within blood pressure. So ACE inhibitors, examples of that for individuals might be perindopril or ramipril, often ending in the word ill. And then the ARBs is another related class, and a good one for that is called candesartan or valsartan. So sartans are the ones that you'll often see, and those are going to be under the A's. B's are beta blockers, and we use these ones to slow the heart rate, and it's also beneficial after you've had a cardiovascular event. So ones that you might notice there end in the word all. So bisoprolol, metoprolol. Calcium channel blockers, many people with high blood pressure will be on this class because it's shown some really good effects. And the examples of that one would be Norvasc, or the chemical name is amlodipine. And we see a lot of individuals taking that one. And the last one are going to be those water pills. And you've seen a few of those. Examples would be hydrochlorothiazide as well as chlorthalidone and or indapamide. Those are just some examples. Often you'll see these products in combination. And for blood pressure in Ontario, if you have hard to treat blood pressure, the average individual will be on about 3 or more medications, so 3 or 4 different classes. So 3 or 4, so almost all of these classes, just to kind of keep that blood pressure under control. But again, more importantly, these medications have uses in other cardiovascular disease, not just blood pressure. And we'll talk about that in a sec. So when to start high blood pressure medication, obviously if your pressures are high, and the doctor is going to be doing some testing in the office whenever you go in. Sometimes they may ask you to do some testing at home. We'll often use these medications with heart failure, or maybe if someone's had a previous heart attack or stroke, we'll use these categories of medications. We also will use them in chronic kidney disease. So we're actually looking for an effect on the blood pressure, but more so we're looking at specifically the effect of the pressure going into some of the organs, so the kidney especially. So even if your pressure is good, you might be put on some of these blood pressure medications to help protect your kidneys. So very, very important to realize that these medications are used for lots of other things. And these are some of the examples. You'll see those choices on the top. The D is the diuretic, the B is the beta blocker. Then we have those ACEs and ARBs, and finally we have the calcium blocker, which is that amlodipine. And all I wanted to take from this slide is each of these medications can be used for lots of different cardiovascular disease. So if you're looking these medications up online and you just see the word blood pressure, hey, I don't have a problem with blood pressure. Guess what? They may be using it for another reason in your particular case. So just talk to your doctor or your nurse practitioner about that one, or your pharmacist. Blood pressure goals, everybody's going to have slightly different goals, and it depends on a lot of things. Other diseases, for example, if you have diabetes concurrently or at the same time, you may find that your goal may be a little bit more aggressive than maybe your neighbor who doesn't have diabetes. We also have different goals based on age. We don't want blood pressures to be too low for the people as they get older, because it increases risks of falls, and that kind of goes along with that frailty. And again, how you check your blood pressure, again, your doctor will decide whether it's appropriate for in-home testing or whether you need to go into the office to have that testing done. Common side effects with most of the blood pressure medications are going to be lightheadedness. We find that this happens usually more so at the beginning, can happen if you're getting up very quickly as well. So it's important to kind of know when this occurs. And for the first few days or weeks, we do tell people to kind of take it easy, get up slowly, and just give themselves a chance not to have that side attack. You might also get a bit of a dry cough, and this can happen from that first class we talked about, the ACE drugs, and those ones often end in the word ill. So perindopril, ramipril. So those are the ones we just want to watch for a cough as well. Obviously, increased urinary frequency can happen if the water pills. An important note here, water pills, it's important that you're still taking in appropriate amount of water. People often think, well, if I'm trying to get rid of it, I should probably not take any in. The actual pills get rid of um, water in areas where they're not supposed to be. So it's important to realize that it's important to still take in and the proper amount of fluids to stay hydrated. And some of them can actually have some ankle swelling, and we see that quite often. Even though it's temporary for some people, most people will see it to some degree with the amlodipine, which is that last class we talked about. Big caution, if you're using any of these blood pressure type medications for whatever reason, it's important to realize that they don't do well or can interact with certain medications you can get without a prescription. Things like anti-inflammatories have an effect on raising blood pressure. Sudafed, cough and cold, anything that says stuffy nose, those ones can be an issue with some of these blood pressure medications. Not so much an interaction, but they will counteract the beneficial effects. If you are looking at a cough and cold medications, you'll also see some that say for people with high blood pressure, that actually is a decongestant free product. So I would recommend just talk to your local community pharmacist when selecting a product if you're taking medications for cardiovascular disease. Big question people are asking about ASA. Should I be taking an aspirin a day? We do know that individuals, if you have no history of heart disease, meaning that you're in the category where you've not had an event, you're maybe taking medications for primary prevention, it's important to realize the evidence is suggesting there's probably going to do more harm than good. And when we talk about aspirin, we're talking about usually the baby aspirin. So again, continue to take aspirin if you've been told to do so by your health professional. But if you haven't had that conversation with your doctor in a while, maybe check in to see what they're wanting for you specifically. But the information right now is kind of leading us to believe that if you've not had an event, you don't have conditions like diabetes, for example, as well, then I think you'd be probably better to not have the ASA. And again, if you are taking ASA and you're wondering about the dosage specifically for you, again, ask your healthcare provider. Interestingly, supplements, natural doesn't always mean harmless. We do get this question with omega 3s. We do actually realize that the latest information is kind of showing that it doesn't do as much as we kind of thought it was. But if you're going to take any kind of supplements that kind of have itself touting benefit for cardiovascular disease, it's important to get a standardized version. So we ask that you look for a NPN or a natural product number. This means that the actual government of Canada has actually gone, and this product has gone through a review by the government of Canada, and at least it has to have some evidence for some of its claims. So look for an NPN number, and you'll see on the screen on the bottom picture, it's usually on the label somewhere where you can see it. It'll say NPN. And again, once again, ask your pharmacist and they'll recommend a product for you, or at least a better one within a particular category. So signs of a heart attack or stroke. We're going to be covering the heart attack first. More so chest discomfort, sweating, upper body discomfort. Some people have a bit of nausea, shortness of breath, lightheadedness. My experience is that individuals wait too long. It's easy to kind of say, you know what, maybe it's something else. Maybe it's something I had at lunch. What I would recommend is, again, make sure if you're having some of these symptoms, rest and wait for a little while. It's important to stop all activity. If you have the idea that it might be happening and you have some ASA available, then by all means, grab a couple of those. And again, make sure you carry your medication list as well. Probably tell somebody that you're feeling poorly. Some people just go for a lie down without telling anybody. It's important that people know And a very important factor for females is that these symptoms are not very much likely within the female population. They don't see all the symptoms that are listed here. More so, these are symptoms we see for males, but females actually show quite differently. So if you're getting some of these symptoms, but not all of them, it may still be a case that you need to get looked at. So signs of a stroke, many individuals watching this video will be familiar with the acronym FAST. And again, looking at the face, is it drooping? Can the individual raise their arms? Is their speech slurred? And you'll see some of the commercials on the TV as well with that drooping mouth showing. And also at the end of the day, the T stands for time. Very important to get assessed and get looked at as fast as possible. And mainly that is going to be to give us the best outcomes if we catch it soon. We have certain medications that are time sensitive. So medications, bottom line for cardiovascular disease, why don't you go ahead, calculate your heart risk, look at some of those screening tools, ask your doctor about it. Based on the percentage risk, you're going to have a decision to make with your doctor. And this is what we call shared decision making. You have a say in this. And really, have the doctor explain to you what that really means. Because if you start a medication for these conditions, chances are you're going to be on them for long term as well. The drug of choice for cardiovascular disease is often going to be a statin. So again, asking your pharmacist or doctor about other medications that may help. If you're experiencing a side effect of the medication, it's important to realize what to maybe expect if you are starting, but also if you get it, what am I supposed to do? And often these are very time limited. They usually go away after a couple of weeks. So kind of stick with it if you can. And again, really important to know your medications or your drugs. So keep track of them. Maybe keep a list with you as well. And that's a thank you. So we're happy that you were able to join us today. Again, I encourage you to look at the actual separate video that we have for the dietary section, heart health as well, the dietary one from our dietitians group. Fabulous information there. And if you have any questions, please go see your provider and also maybe your community pharmacist as well if it's related to medications. Okay. Thank you very much and have yourself a great day.